David,
Laura,
we are back.
here we are in the studio again.
Season 2.
This is so exciting. I'm so glad we get to keep doing this.
We have so many fun episodes planned. It's going to be lit.
It's going to be a great lineup.
Right before we came in here, I heard from a Glennon mom that we both know very well.
Oh, who is it? We know a few.
We do know a few. It was Monica, Barrett's mom.
Oh my gosh. What's Barrett up to? We haven't seen him in forever.
He literally just graduated kindergarten, and I'm so excited. She sent me a picture, and he's just cute as can be.
Man, time sure flies.
I know. I remember when we first captured his story, and they were willing to share their Glennon journey with us. And gosh, he was a baby, and he had so much going on. He was born with so many things. He had heart problems, and he had respiratory problems, and he had so many things. And I remember he was going to be going home with a trach and, you know, feedings and monitors and oxygen and all kinds of stuff. And I remember Monica having to learn all of this and how, like, what an overwhelming feeling it was to be going home. And I just, more and more kids like Barrett are being discharged and going home, and parents are dealing with this kind of stuff. I read some kind of article where kids with complex medical needs is the most rapid growing subset of kids in the nation.
Oh, wow.
Yeah. So it's a lot. And, you know, parents didn't used to go home with all this stuff. Kids used to live in the hospital if they had all this stuff. But, you know, that's not the deal anymore. They're going home and they're living with all this. It's crazy.
I just can't even. I'm trying to think and put myself in the shoes of a parent, because we both have kids. I've got two very healthy boys, and I'm very grateful for that. I can't even imagine coming home from the hospital and having to learn all of the different things that I would need to do just to keep my child alive at home outside of the hospital. I mean, that's got to be such a scary and overwhelming and daunting thing to immediately have to be trained to be like a one-man band care team for essentially like a trauma case.
Right. I mean, the safe place for these parents in the beginning is the hospital, right?
Right.
You know, the hospital knows how to do everything. And then you transition to become the subject matter expert on your kid. You know, the hospital's still the safe place, right? But you become the master of everything. So, and then, you know, you learn everything, you're instructed to do everything, but still, you know, the advice is, okay, do all your things. Here's how to troubleshoot. Here's how to manage all this stuff. But if you get into trouble, you call 911.
Absolutely.
Right? Okay, so here's my lens of 911 in the past, right? Remember the show Rescue 911 from
totally.
the 80s or 90s or whenever that was, right? Paramedics, first responders are like the heroes, right? They know how to do everything.
Yeah,
so,
superheroes.
you know, right. So if I have, you know, my kid at home and I get into trouble, I'm going to call them and they're just going to know what to do, right?
Right.
But honestly, if you talk to the boots to the ground people and you talk to the paramedics, and I've talked to a couple, and that's really not the reality. And I don't think I realized that till a few years ago when I started having conversations with people and I started thinking about all these parents that were sending home with all this stuff, you know, and it's like, so y'all know how to take care of that, right? And it's not. It's kind of like nursing for me. Like, I graduated with my nursing degree, but I don't know that I could deliver a baby because I don't do that every day, right? It's not my forte. It's not the niche that I work in every day. I couldn't take care of the child on ECMO because that's not what I do every day, right? But I just had this naive assumption that, well, paramedics just know how to do everything, right? Because they're the 911 people.
Right. They're the ones you call in case of an emergency. So, like, what do you do if they come to your house and they don't know how to handle a patient who's on a ventilator or something like that?
Right. So it's a gap. I mean, it is a real gap. There's minute level of education on specialized stuff. And so they're taught bare bones basics on things, but not the nooks and crannies of Johnny, who has a trach and a vent and things like that.
Right.
That's not the reality when it comes to the training. So, you know, where we were like 15, 20 years ago is the EMS folks that were, you know, coming across these types of kids in home settings. They were finding themselves not properly trained to the level that they felt should be necessary to manage these calls, right? So they were reaching out to Glennon saying, "Hey, we're noticing, we got kids and we're getting these calls, and we want to have better outcomes, and we want to know that we're doing better. Can we get some training and things like that?" So sets of calls, sets of situations like this led to the pilot of a program, I don't know, 15 or so years ago that Glennon adopted. And it's a very special program that we love to talk about at the foundation. And we are well familiar with it, but a lot of people are not. And it's called S.T.A.R.S.
What a fun name.
Special Needs Tracking and Awareness Response System.
Well, that makes sense.
It's a lovely acronym. And we took a chance on this program that was really a vision of a paramedic in the community who was, experiencing all of this and saw the need and said, we need to do better. And essentially, the idea behind it is to improve the emergency response and care of medically complex children. So without giving it all away, that's who we're having here today on the podcast.
Oh my gosh, I'm so excited. So we're getting somebody from S.T.A.R.S itself, the program who's going to be talking?
We are having the two bookends, I guess, of S.T.A.R.S. We are having Nick Salzman, who is the current program coordinator of S.T.A.R.S.
Awesome.
And we are having Jamie and Tim Massinelli, who are amazing S.T.A.R.S parents.
Oh, they're fantastic.
And their son, Kellen, is a S.T.A.R.S patient. And we're having them both on today to give their perspective on kind of the need for the program, how it all got started, where it's at, where it's going, and to talk about what I feel like we consider is a true gem that started at Cardinal Glennon.
I know. I'm so excited. This is going to be a very strong story, and I can't wait to get into it.
Welcome, guys. How are we feeling today?
Feeling good.
Good. Okay, we got Nick, who's our program coordinator for S.T.A.R.S, and we have Jamie and Tim Massinelli, who are S.T.A.R.S parents. Y'all are truly stars in my eyes, not to make a pun already, but so I'm just going to be out there with it because David knows I like to share my ignorance of things publicly.
Well, you know more about medical things than I do.
Oh, well, not when it comes to this. So I will just admit from the get-go that my knowledge of EMS, the EMS system, the training that it takes to work in EMS was essentially zero before I learned about S.T.A.R.S a few years ago. So my perception of what reality was based on Rescue 911. Do y'all remember that show from like 1989?
Yes. So tell us, Nick, is it really like Rescue 911
like
every day?
I loved that show, literally. And I just thought that paramedics were gods, right? And that
if you ask
they could do.
Of us.
I just thought that y'all could do anything and you could handle any emergency, right? But the reality is y'all can walk. You do walk into situations that you are not prepared for, which in healthcare is dangerous. Like when I was a nurse, I didn't do intensive care, but I would get floated every once in a while to like an unfamiliar unit, and they would never assign me like the post-op heart patient or the patient on ECMO, right? Because those would require specialized training and training on the equipment. But y'all don't know what you're going into. So how could they possibly train you on everything, right? They can't. So
that's where we have the S.T.A.R.S program come in, right? And Nick, can you remind us what S.T.A.R.S is an acronym?
It is. It stands for Special Needs Tracking and Awareness Response System.
Wow.
So the ultimate goal, please step in and correct me if I'm wrong, right? But the ultimate goal of S.T.A.R.S is for the EMS and community hospitals to be familiar, right, with high-risk children in their communities, have pertinent and up-to-date information about each S.T.A.R.S child in the hands of the first responders before they need to respond, right?
Absolutely.
For the first responders then to get the training that they need and be prepared for the emergencies, and ultimately kind of have the EMS system be an extension of the child's care team that's kind of built up in the hospital walls, right? Because that's going to help decrease the anxiety of the first responders, decrease the anxiety of the families. So I think I want to start first by exploring the need, right? And address the need first from the paramedic side. And then we're going to get to you guys and address the need from the family side with Jamie and Tim. Cool?
Absolutely.
Okay, so Nick, before you worked at Glennon with S.T.A.R.S, you worked as a paramedic. So tell me where you worked and what were some of the most popular calls that you got? Like, what was a typical day today?
Yeah, so I was a paramedic for about 12 to 13 years before coming to S.T.A.R.S. I'm a classic millennial. I can't hold a job, so I've worked at many places. I started here in St. Louis at Abbott. I worked for about 5.5 years for St. Louis City Fire Department, EMS. From there, I went to Aerovac for a year and flew with them for a year. And then I was working part-time at Rock Township Ambulance District for many years, and then took a full-time job there for 3.5 years prior to coming to Glennon.
So, so EMS training. So you got to be prepared for a lot of different types of situations because you don't always know like what you're going to go into. What is, I mean, I guess base core EMS training look like? Like what are the main things that they are trying to prepare you for the situations that you might be called to help out with?
Yeah, so, and you guys kind of already alluded to the challenge a couple times here, but to become an EMT and a paramedic, you're looking at 16 to 24 months of training. They try to cram all of emergency medicine into your head for those, 1 to 2 years of training. And so almost by necessity, it kind of gets really narrowed down to life threats and these major emergencies that we're all, trained to make a difference in, the time critical diagnosis calls. So stroke and STEMIs, which are heart attacks, and trauma calls. And so you get kind of a ton of training on a really small niche of emergency medicine. And then we just sort of try to fill in the gaps the rest of the time. And unfortunately, a lot of that is not always covered in your primary education, or it's not covered super thoroughly in your primary education. And so EMS is one of those fields where you just continuously train as part of your professional career after you get your license. So, I mean, in the state of Missouri, that looks like 144 hours of training every 5 years. And or if you do the national standards, you're looking at like 64 hours of training every 2 years. And so a lot of continuous training, but it's really hard to hit some of the smaller patient populations of what you really need to know for a handful of patients and especially kids that have very specific needs, that you need very specific knowledge bases for what to do for them in an emergency. And so we do the best we can in EMS and primary education and continuing education, but there's always sort of a bit of a game of, did you call 911? Like, you didn't get to choose, right? Like, you didn't get to call 911 and say, oh, I want that one and that one and that one to show up.
Right.
You get who you get, and there is a certain amount of, were they trained in what you need them to know when they get there. And so that is a challenge in the educational setting for EMS.
Well, one more, probably based off of where you are located, it's going to be different types of training that for the types of calls that may be more frequently, like something being called to something in the city could be, like to your point earlier, into some of the smaller communities could be different than like a typical call that you have in a more rural district, right?
Absolutely. So yeah, some localization to the calls for sure. And really even just day to day, regardless of where you are, right? Like you can have a day where it's just, helping somebody up off their bathroom floor, and then maybe just taking somebody who's had a headache for the day in, and then you can show up the next day and, you can have interstate accidents and all kinds of things going the other way. And so, yeah, I we don't have to go all the way back in my background, but I grew up in Texas, so I know how to play football. And I have always equated it to being like a cornerback. Like you just come up to the line and you don't know which way everything's going to break, but you just get up on your toes and you're ready to go with the call.
So I want to hear about your first encounter with a medically complex child that you were not prepared for pre-S.T.A.R.S. So pre-S.T.A.R.S, what was, if you don't mind sharing?
Yeah, and I couldn't even say. I have a couple of memories of calls and experiences before, and you know, especially I was working down here in South City, and we had a family that we went to pretty frequently, and I don't want to hurt the Massinelli's feelings, but you know, you in EMS, you go to an address once and like, okay, they needed some help, and then you get called there a second and a third and a fourth time, and at least this was 19-year-old Nick Salzman we're talking about, all right? So first of all, just so we get that clear,
Yeah.
you know, and then you're like, well, this, I don't know that we need an ambulance day after day after day, and so what you're starting to see, of course, is bigger problems and families that need support, and but then you also then turn the next page where you're like, oh, I know this family. Like I walk into their house and I know them, and I've met this kid before, and I know where they need to go and how we're going to move them out of the house. And so, you know, it sort of can occur kind of naturally like that. We of course in S.T.A.R.S want to accelerate that process of knowing them ahead of time. I think to maybe get after a little bit more of your question of a call that really stands out in my mind. We did the best we could for a very critical kid for a very critical situation, and we got them to Cardinal Glennon really quickly. And you know, we thought we did a great job, and maybe by the standards of the time, we had done a great job. And you know, you know, just short of high-fiving each other in the bay. Like it was an 8-minute call, I think, from getting the patient to arriving at the ED. So everything was happening super fast, and we thought we had done everything well and medically appropriate. And I do recall a little bit of the ED not being quite on board with, like, you know, our feelings towards the call, like, but nobody really said anything. And it wasn't till years later, actually, as I joined S.T.A.R.S and I came here, and you know, I was working with Trish, who had started S.T.A.R.S at the time, and she was talking about calls and what we were going to do education on and what we were going to try to improve. And I said, you know, I think I have a call like that. And she's like, you do. I have the trip sheet. So Trish was sitting there with the trip sheet, and it was part of a study she was working on of how we could make a difference. And, you know, a couple things dawned on me. You know, we didn't know what we didn't know, and that's part of why I work so hard to try and change that. But also the fact that we have to improve lots of things here, right? Like the communication between hospitals and EMS. It took me getting a job and 6 years later for somebody to say like, hey, you could do this better. And so, you know, and I think how can we carry that? How can we improve that feedback loop to make providers better out there in the field? And so that's a call that will always stand out to me. I teach on it every now and then. It is not my favorite call to teach on, but I think it really highlights, you know, it really demonstrates just how knowledge gaps, like, if people don't, it really speaks to that point. People don't know what they don't know. And if we haven't taught them, we can't expect the system to get better. And so.
Well, I want to keep on this topic of need here and pivot to Tim and Jamie for a little bit. So the two of you are parents to a medically complex child. So tell us about Kellen. Tell us about the pregnancy, the beginnings, the diagnosis. So I don't want to get into your relationship with S.T.A.R.S just yet, but just give us background.
Okay.
You can do it.
I can do it.
You can do it.
So my pregnancy with Kellen was wonderful. Like I had a very typical pregnancy. I didn't gain like very much weight, which was awesome. And for everything we knew at that point, that Kellen was a healthy baby boy. And at 4.5 months old, we did not know what an infantile spasm was. And so we went to the ER twice, and he never did it in front of them, but we would tell them, you know, at Anderson Hospital, what was happening. And they took x-rays, and they're like, well, we can see all this stuff in his belly. And so But it was just gas. So he was rolling into a ball and then he would release and he would like curl up and then release. And I did not know that that was a seizure. And
how would you know that?
Right. I had no idea.
Right.
And so on a Friday, the journey started. We were both taking a nap and my friend called me just to check, new time mom, first time sick kid, you know. And I got up and I walked over to the pack and play and he was blue. And so I got down, I gave him mouth to mouth and he started breathing and I crawled to the phone because I was going to call 911 and Tim called me right at the time. So I just started putting on my shoes and getting the pumpkin seat ready. And I'm like, he wasn't breathing. He was blue. He's okay now. And so we went to the hospital. And it took a few hours before he did it again. And they had us hold him upright. And I guess they knew exactly what was happening. And they told me they'd already called Cardinal Glennon and they were going to come pick us up and take us there. And that it was a seizure or seizures. And I was like, what? You know? And so even then trying to be like, okay, it's seizure, maybe he's sick, you know, and everything's going to be okay, you know. And so that was really hard following him in the ambulance. And I will tell you that the the transport team that came to us, they were wonderful because they knew I'm like totally trying to keep it together. And they're like, we know you're scared. It's okay. You know, I'm like, okay. And it progressively got worse, you know, that night. And then he had an MRI. That was on a Friday. And then he had an MRI on Monday. And they told us that he had a smooth brain and that he would never walk or talk or sit up. So that was the beginning.
Let's emphasize the fact that you resuscitated your baby. Can
So-
we just give you props for
So
a
really
second?
quick on the I remember during pregnancy, her taking classes, right? CPR classes. And we're all, you know, I'm like, make fun of her a little bit, like, good mom, you're being such a great mom. How great, thinking, you know, you'd take those because you don't
You're
ever
never
plan to
need it.
use them.
Mm-hmm.
Mhm.
And I think back, I'm like, oh my goodness, that's exactly why you take those classes. And we're so very happy you did. So, yeah.
So in the beginning, you know, you're handed this diagnosis, you're told all of this heavy information, and Cardinal Glennon was your safe place, right?
Yes.
And they're telling you all this, that's where they know what to do. They know the words, they
Right.
know what it is that Kellen's dealing with, right? And so you're dealing with, you go home at some point after this initial diagnosis, right? And before S.T.A.R.S, when something unexpected happened, right? You probably felt pressured to get Kellen back to Cardinal Glennon, right? Because they're the only people who know what to do besides you being
Yes.
taught, right? They're the people that know what to do. And you don't want to go through the process of like dealing with somebody else, right? So
Mhm.
you just get him in the car and
Go a
bring
lot
him
of
to
times.
Cardinal Glennon, right?
Mhm.
Yeah. So I'll tell you really quick. From that first hospitalization, when we found the diagnosis out, we were in the hospital for about a week, and the seizures were just getting worse. Right. We're trying to figure out what medications are going to work, how we're going to handle these. And I remember at some point, like the day of discharge, I'm looking at the doctors. I'm like, "Was you're sending us home?" Like, I don't know if in my head I thought we're just going to live here, right? Because what are we supposed to do?
Right. We don't
'Cause I'm
want to
like,
do
he's
this.
seizing
Like, it's
as
scary.
we're taking him out to the car, and he's seizing. We're like, we're looking at each other like, oh, that's what this is like. And to your point, Laura, at least first year, if not more, we were back in the hospital like every other weekend. We're just learning this. Help us. And that, because we kept going back to the place that we knew was going to fix this, you know, and that was our fear in the beginning. And that was sort of led us to like, and what happens at home? How are we going to handle this if all these happen at home? We knew, and we were just scratching the surface about how
and
complex
it's like,
it was.
we're just not going to sleep. We're just going
Yeah.
to, we're just going to stay up 24/7 and
Mhm.
We did.
wait for the things we don't want to wait for, right?
Yes.
So, so this vulnerability isn't good for either side, right? For you guys, Nick, and Nick, you worked at Rock Township, you said, and you worked with the creator of S.T.A.R.S, Trish Casey, right?
I
And
did.
she built the program while working full time as a paramedic at Rock Township. And she too is a mother of a child with special needs and recognized the pitfalls that EMS can run into when called to care for children in the community. And she started there, right? Start with home base, who are the kids in our own district that might need us? And so she started identifying the kids in Rock Township to pilot the S.T.A.R.S program and approached Cardinal Glennon, thinking this would be good to have a hospital-based program. And it was quickly adopted by Cardinal Glennon, and she left her paramedic position to be the first S.T.A.R.S program coordinator at Glennon. Yes?
Yeah. Yeah, and for anybody who's met Trish, like, she's incredibly passionate about whatever she's working on, and she found a problem, and she went to go look for the solves that were there, and the solves were pretty lacking at that time. And so, yeah, I give her endless credit. Like, it's what she did is amazing, and it kind of fortuitous and amazing too to encounter personnel at Cardinal Glennon who were looking to solve similar problems from the hospital side. They were, saying we want better outcomes for our patients outside of our four walls. And we were the people outside the four walls who were saying, like, we want to be able to do better for these kids. And so it was just kind of an amazing moment in time to marry up those two.
Nice little marriage, isn't it? Yeah. Well, okay. So I want to dive into how S.T.A.R.S works. And we're going to start with the enrollment of kids into S.T.A.R.S a little bit. So how are children who could benefit from S.T.A.R.S identified and brought into the program? Are there criteria? Is there a referral process? Like, how does it work for a child to be identified and said, you should be a S.T.A.R.S patient? How does that work?
Yeah, and so just to be clear, this has sort of evolved over time. So sometimes when you talk to people about S.T.A.R.S, they're like, "Oh, this is how S.T.A.R.S works," and I'm like, "Oh, that was how S.T.A.R.S worked 4 years ago. It's changed a little bit." But yeah, so we do have inclusion criteria. We have some referral patterns within the hospital. So the complex care medical program is one of the primary programs that refers kids to us. Also, our NICU and our NICU discharge coordinators, our TCU discharge coordinators, they're kind of aware of us and the inclusion criterion. So anytime a kid's had a procedure or a surgery or a diagnosis, and they say, we think that this would be a good referral for the S.T.A.R.S program. And so they'll send the kiddos to us and we'll do the evaluation and see if they're appropriate candidates for the program and enroll them at that time. We do still take a handful of referrals from EMS as well. So if you have an agency and they say, like, "Hey, Nick, we've run this kid like 6 times this year already, and our crews are really struggling to know the right thing to do for them. Would you guys consider taking a look?" And so we'll take referrals from EMS as well. Once we've identified that kiddo as a good candidate for the S.T.A.R.S program, we will build their form on our website that we run for S.T.A.R.S. We write the plans. It's actually paramedics and a respiratory therapist and nurses who write it. We get physician approval, just in case anybody's worried. But we find that it really takes somebody who understands what's going on in the field to get a good set of instructions. And then when we finish with the plan, we'll submit it to our medical direction for approval. That's usually Dr. Laffey here at Cardinal Glennon. It's Dr. Joe Finney for our partners over across the street at St. Louis Children's. So each pediatric hospital that participates in S.T.A.R.S has an identified medical director who will approve the plans. Even after they approve them, it's actually not a live plan. The plan then gets sent to the EMS medical director for the agency where the kiddos live at, and they have to approve it as well. I know this all sounds terribly complicated, but it actually has a good foundation, a good reason. And that's because of how EMS works. EMS providers are very rule based.
Mhm.
Like we follow sets of recipes that keep us, safe most of the time. You get the cake right 95% of the time. But, what we've really identified are groups of patients who don't obey those recipes, who don't obey those rules that EMS was just taught to follow. And so we want to have permission. So basically we have a pediatric physician who says, yes, this is appropriate care for this kid. This is the care they need to receive in an emergency. And then we have an EMS medical director who says, I give my crews permission to go follow whatever care is written in this form. So by combining those two elements, we're kind of able to have custom made plans for the kids.
So I'm going to press pause.
Yes, ma'am.
And we're going to, I hate to use this phrase, but we're going to dumb it down for people who really don't understand what kind of child this is that would be a S.T.A.R.S patient. So when we talk about inclusion criteria, without identifying children, obviously, what are some of these things that would make me a S.T.A.R.S child? Like, what's going on with me that makes me complicated?
Yeah, so our kiddos that get included in S.T.A.R.S, a lot of times either very medically device dependent or like you kind of said, very medically complex diagnoses. So any kid who's got a tracheostomy, a tube through, their neck that we can breathe for them, or requires being on a ventilator all the time, or even part of the time, would be included. We also include kids who are, incredibly prone to seizures. We want people to know how to treat them. And sometimes if you have a kiddo who's really prone to seizures, they have slightly different treatments than everybody else out here in the world. So knowing some of that specialty care for them. Some of the kiddos who have really sick hearts, right? Like they were born with either, plumbing crisscrossed or huge holes in their hearts. And we're having to do some pretty advanced procedures to help that heart function each and every day. Kids who really, if we get off into some of the syndromes, especially metabolic syndromes, have specialized requirements from that. And in all honesty, in S.T.A.R.S, we always have to have kind of a category at the end of, just kids with incredibly rare diseases who we need something different for them, right? Like they need to be transported differently. They need different care or medications, or just even awareness about them so that you don't do something you normally would do that might harm them. And so we kind of always have to leave ourselves a little bit of wiggle room at the end because we haven't maybe finished identifying every group of kiddos that needs to be in S.T.A.R.S. And so that would be kind of a pretty common inclusion criteria for us.
For sure. For sure. Okay. So now I'm going to pivot back to you guys, Jamie and Tim, as far as Kellen. So you talked to us about the very beginning and that he was having a lot of seizures and he was little at the time. So you're home. He's 4.5 months. So now I want to continue that journey. So talk to us about him and how his care and complexity kind of increased and evolved with you guys, and what day to day was like with him at home and what you all were managing on your own.
Do you want me to take this one?
You can go ahead. Yeah.
Okay. So I can tell you taking him home from the hospital from the first diagnosis, we certainly, we did, we used to talk about not knowing what you didn't know. We didn't know anything, right? And I can remember we even tracked his seizures in an Excel spreadsheet. We just thought like somebody's probably going to want to know this stuff. Looking back, it was kind of dumb, funny, but that was the sort of like, how are we supposed to figure this thing out? And so we would come back to the hospital an awful lot. We relied so much on Glennon and the doctors, and it was great. And then I think at some point, as things got so much more complex with him, I remember talking to Jamie is like, so kind of what happens? We know what's going on with him. What happens if something happens at home? And the S.T.A.R.S wasn't even a thought, right? And I remember talking like, oh, maybe we should let someone else know besides just us two.
And Kellen still went to my aunt's to be watched.
Yeah, so at that time it was just
part-time
it was just we were like, she was a babysitter, but he had a feeding tube, and there's all these things that she had to care about. Like, well, maybe we need to tell the EMS in her area and the EMS in our area. So like, well, let's jot some stuff down, some important information, and at that time is maybe just a few things meds, and he's got feeding tube and all these things, like, so they know him, right? And
Well, and I feel like, okay, I find it funny that now y'all are older and such experts on him, but at the time, okay, these few little things that you're meant, oh, he's having some seizures and he's got a feeding tube and he's got all these medications. Okay, Joe, average parent, is not doing
No, those aren't
any
little,
of that.
and that's
Those
more
aren't
than
little.
a few.
yeah, they seem
Right.
little now.
Right.
So the one of the best ways I think I can help answer that question about what's a day like with him is, so imagine your loved one is in the PICU or ICU, right? And you're in there for however many days, and he's got all these things hooked up to him, right? You ever see those pictures where there's things hooked up to him and you look at him like, what are all those? And it's leads and it's IV lines and it's, whether it's tubes down the nose or, leads on his head or whatever. And it looks so complicated, right? And there's a ventilator here, and then there's like, like respiratory's got all their equipment in there.
Oximeter.
There's all this going on. So quite simply, our living room is a slimmed down version of that, without the medical professionals, without the doctors, without the quick response, and without any kind of medical degrees on our
Without the
side.
call light.
Without the call,
Right.
without anybody
Yeah.
looking through our picture window going, oh, he's destat, we're going to run in and save him. So imagine most families, for the most part, you come home off of those things, right? In an attempt to get better. The doctors will say, take it all home with you, because this is what he's going to need to sustain life. And you two will be solely responsible for all of it. Good luck. So imagine you taking that home. Most of you just leave, right? You take your loved one home, all that stuff stays behind, maybe go home with a couple things, they get better. That's been our life for nearly 17 years. That's all those many traumas you have in the hospital and PICU, those are every day. So we talk a little bit about like, it's just a few seizures, because that's the way it used to be. It's so much more complex. It's your everyday life. It's what you become accustomed to, and you can absorb it, you can handle it, you can deal with it. And then little did we know, there's all these gaps in care. And then we were doing things that we didn't even know there was a gap. I remember there's a gap in EMS and response. We didn't know how to fix it. And then I remember hearing about this going, oh, there's like 12 different incidents. I mean, I could have, why didn't I think of that? Why? Yeah, somebody fixed this. We needed the solution, right? And you guys eventually brought it to us.
But before that, what
It was
did you
us.
do? What did you do on your own? So he's little at this point. We're a year or so in to birth, to life, whatever. And you're starting to realize the trajectory of where this is going. You're managing, some meds, some G-tube feedings and seizures. So, and to your point, Tim, somebody else besides us should know what's going on with them, right?
Mhm.
So what'd you
Yes.
do?
Well, I mean, it was really hard. I mean, we didn't realize how hard it was until we got help, because Kellen had to continue to evolve for for us to qualify for things, like for nursing care and those pieces that help with our quality of life and Kellen's quality of life. And we've called an ambulance 3 times in Kellen's life, and they were all pre-S.T.A.R.S. And the second time that we called, Kellen has seizures all the time, but I called for respiratory distress, and he didn't have a ventilator at the time, but he did have a tracheostomy at the time. And so I'm calling 911 because it is beyond me, which I think probably takes a lot to get beyond me at this point. And they walk in and I could see the looks on their faces. And I'm like, oh no. And so I pulled it together because I had to find all the pieces, because I'm like, do you guys have the piece of, the little adapter that goes over so we can run the oxygen? And they're like, no. So I had to get everything all together and help them. And we got him into the ambulance and we are off to Cardinal Glennon because they felt that he was stable enough so we could bypass Anderson at this point. And I'm in the ambulance. Riley was just a year old at the time. So I'm in the ambulance with Kellen, and all of a sudden Kellen starts seizing. And I could see everybody like, they're like Ativan, and I'm like, whoa, 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 whoa. I'm like, nobody do anything. They stop and look at me. I go, he has seizures all the time. I go, we're not here for seizures. I go, we're here for respiratory distress. I go, he's fine. I go, you don't need to stop the seizures. We're good. And they're like, are you sure? I'm like, yep, I'm 100% for sure. I'm like, this is normal. That is normal. How he's breathing is not normal. I said, but I go, I don't want you to put any more into him, and thank God, I'm like, I guess, I sold it well enough that they believed me, like I knew like he didn't need that. And I wasn't sure what was going to happen. And we've never used Ativan. So I was really scared, like, well, what was going to happen? And so I was super grateful that even in that small few minutes that there was still a trust that maybe they just recognize that, well, she's taking care of this little boy who's complex, that she does know what she's talking about.
And he had a plan, right? Like you guys have his care plan.
Yeah.
You know what that is, but no one else has that care plan.
No.
Yeah. And to add to that, it's funny how things come full circle, right? So that was maybe 10, 12 years ago. I work for a home builder on the Illinois side, and we built this home for this family, and I'm in their house a year later, so doing some work, and we had met the homeowner a couple times, and we're talking a little bit. I'm like, I have kids, and Kellen Massinelli, he's like, I know Kellen, I've been in your home, and I'm like, you've been in my home? He's like, I'm an EMT. Yeah, I'm an EMT. He was like, I remember your wife telling me in the ambulance going, and he's like, he seizes, and I'm like, get Valium. And your wife's like, no. And he's like, I was kind of like, okay. I met him 10, 12 years later, and he like, I've been in your home.
That's crazy.
And he was telling me the same story that she just told. He's like, yeah, I saw a seizure, and I was like, okay, do this. And your wife's like, stop it. Come on. No, he's fine. We're here for it. And I was just sort of like taking her lead. And it was.
So you guys told me about a time that you actually walked up to your district and presented them with Kellen's plan. Tell me about that. I don't know if that was pre this episode or post that episode, but
I think it was pre, right? Because it was early on. I think when he was really young, I think we talked about like, I think it may have stemmed from like, I think at the time it was like, if you have equipment or like ventilators, let Ameren know you can be priority. So there's in our head, I think we were like, well, what can we do to be proactive?
It was with the trach because
it was probably with the trach. So early
humidifier,
on.
No ventilator or anything like that.
So like, what do we do to let other people know? And so we were like let's put together we call them care plans. Let's put together a bunch of notes about Kellen, what he's on, and let's get it to the fire departments. And I remember taking it to 2 at the time, where he was being watched during the day, so we could work in our home, and thinking. And I think I talked about like how quickly he aged out of those notes and who he was. He got more complex. And I remember thinking at some point, we gave up on it, thinking like, well, he's got a ventilator now, and they're gonna look at that thing back then, and he's got like 20 meds now, and he would get to 40. Like, it's useless now. We just couldn't keep up on it, right? It was like, I think we probably needed to update those things like every 6 months, and we were just sort of like, we did it once, and we thought like we did something great, and that was it. We're like, we never went back to it. Little did we know, we sit here talking about like, we've got a care plan now. It's through S.T.A.R.S, and it's a great little PDF available.
So so walk me through, you kind of talked briefly about a day-to-day, but at this point, what is his care like at home for you?
Well, it would, day to day, we had meds at very specific times that we had to give. And then having the tracheostomy, it was just normal care, around the trach, around his G button, to make sure that everything stayed healthy, his skin stayed healthy. So that way, the things that we could control, we can control. And then suctioning, making sure that, everything was administered at a specific time. He was also, at 6 months old, put on the ketogenic diet because his seizures were so bad. I always find it fascinating that, they told us that he was one of the youngest to be put on the ketogenic diet at Cardinal Glennon at the time. And Kellen was just, he got so complex so quickly. He had a tendency to seize every 2 seconds. And so it was really scary. I mean, I was scared all the time. And it took me a long time to just be able to breathe and not be scared and be able to, maybe be scared later, like probably what nurses and people do today in the medical field is just, so now it's just, our everyday. We still do all those things. Now we do airway clearance vests because he doesn't move, so all of his secretions, sit in his chest and he doesn't cough. So then we also have to do a cough assist so we can pull all of those secretions out of his lungs. We do breathing treatments, multiple times during the day. We did back then, we were doing albuterol. It was clockwork every 4 hours, and
24 hours a day, right? So the med stuff she's talking about, 7 different times in a day, right? 8 a.m., 10 a.m., 2 p.m., 4 p.m., 8 p.m., midnight, 10 p.m. at night. 24 is you don't shut it off at 5 o'clock. Straight cath them 7 times a day, right? You run nebulizers every 4. You turn them, right?
Every 2 hours.
Clean all. He can do nothing for himself. You change diapers when he's 16. That never goes away. You deal with respiratory. You have to understand the ventilator. You have to understand to make sure he has oxygen. He has to make you have, and for us, he didn't like get in an accident one day and have all these things at one day. It progressively, he got the trach at maybe 1 or 2 years old, and then he got the ventilator, and then he got the cough assist, he got the airway clearance vest, so we were able to absorb it, and then now it looks like a mountain of care. He's on 40 different meds. We at least 40. I don't even know, but where we had to have a system to put them together once a week and work with all the different places we get the meds at and the insurance companies and all. So it just kept getting bigger and bigger and bigger and bigger and bigger and more and more and more complex. And thank goodness, as it's gotten complex, there's like places like S.T.A.R.S program, and we've been Glennon forever. Glennon's been great with this, but a day in a life is literally every time we talk about this all the time. Like if it's 11:30 or if it's 12 or 12:30 right now, I know he gets a clearance vest at 12:30. He's going to get feedings at 1. He gets meds at 2. We got to cath him at 2. When I see a clock, those are the things in my head. I know the schedule is in my head, right? So those are the things you think about all the time. And so imagine we talk about how complex it is if we just walked you into our home and said, take care of him, good luck. You're going to be like, oh, okay, like what, we got to do all these things right now. And I think we early on, we thought about that. Like, what if somebody walks in here? How are they supposed to care for him? And that's when she talked about like the EMT coming in going, okay. And we're like, well, these got all these other things that maybe you don't know about that are part of his care that we just knew they didn't know. So then we started taking things into our own hands.
For sure. Mm-hmm. So tell us about the second call. You said you had a few calls pre-S.T.A.R.S.
The second one, I wasn't at home for. I was actually at work, and they called me to tell me that they had taken him by ambulance to Anderson. And he was really sick and not stable enough to go to Cardinal Glennon, so they went to Anderson. And his Mickey wasn't attached, the tube that's attached to his G button, so he could get meds and feeding. And when they got there, they needed to give him some medication, and the ER nurse didn't know how to administer it. So, I mean, it's those things that it just became really eye-opening for us that outside of Cardinal Glennon and us, nobody could help us. And that's scary. And that's a lot of pressure.
Yeah. I remember being very surprised. I remember, and she's like, very, very upfront about like, I don't know how to administer this. She's like, so for us, what we took from it was like, what are we doing here? Right. We need to somehow, we called the ambulance. Ambulance took us to a place that we think you shouldn't have took, again, we just think you should know everything, right? I mean, that's kind of what I think is ingrained in us. Like, you should know everything. What are we doing here? I think those are the moments, Jamie, we talked about like, we need to just start taking, we'll be the EMS. We need to take him to Glennon because we don't want to go. We've been through that. That's bad. We're going to go. It's 30 minutes. We're 30 minutes. Imagine the patients you have that are 2 hours away. I have no idea what they do, but we're just going to drive and we'll take it in our own hands.
So did you have episodes of that? So you have these 2 calls, right? So this is your experience that you have in your head, right? And then did you have another bad scariness that you just said, we're just going to plop them in the car and go right to Cardinal Glennon?
My second time I ever gave Kellen CPR, we were in Shop and Save, and we were in the frozen food section. We're almost done with grocery shopping. And I'm at the other end, and all of a sudden I hear Tim go, Jamie, he's not breathing. Jamie, he's not breathing. I run down to the end. We put him on the floor. I gave him mouth to mouth, and I scooped him up then, and we just ran, and it wasn't even a thought that I was going to call an ambulance. Nobody did anything. So there were people in the aisle, like, I think they were
frozen.
They were
in the frozen food
There was a lady
section.
over her shoulder panicking.
Yes.
And we were kind of like, is she going to be okay?
Tim thought that I didn't know.
I felt bad for her. She was panicking. You could tell she
Panicked
wanted
woman.
to do something. She didn't know what to do. She got him. We're like, he looks good. And I think we even like pulled the cart up to the front, like, we're leaving. It was full of food. And we just drove straight to Glennon. And knowing the whole time going,
should we be
doing
doing
this?
First of all,
It worked out.
like, you took him to the Shop and Save with all his things, right? So which is what parents
Most
do
people complain
when
about
this is life,
taking
right?
kids to the grocery store, but this is a completely
yeah.
different
Yeah,
experience
most
that you
parents
all have.
complain about their kids acting out at the grocery
Wanting
store,
the Kool-Aid
right?
or the sweet
Yeah.
treat or something. Yeah.
So you get
I
to
think he was just being
Cardinal Glennon.
dramatic, Helen. He's wanting some attention.
But it's what you do. Like, like, he's safe with us, right?
Correct.
Because we know he's safe with us. So we're going to go with what we know is safe,
And
right?
yeah, and I don't know, we'd always done everything together. So, that didn't change for Tim or I, and it hasn't changed where we want to do things together. And that meant, taking Kellen with us and Riley. And I mean, yeah, one of us could have stayed home with Kellen, but we were like, oh, we'll just, it's a nice little, going to the grocery store is a
Right.
nice little
Field
get out of
trip.
the house,
Yeah.
a little field trip. And
that need, that need hasn't changed. And we talked about, we haven't called since. But I can tell you, just back in March of this year, we talk a lot about, like, one of the most difficult things when you put yourself in this position that we were in is, how do you know when too long is too long? Did I wait too long to call the professionals, or did I call the ambulance? Did I wait? And that's a lot of pressure, right? You look at each other like, he's still good. He's still good. He's still good. He's still good. Oh crap. We should have left. We should have went, we should have left it, or we should have called. That's always been there. And he got really sick right around St. Patrick's Day, and he was destatting fast, and we knew something wasn't right. His breathing was an issue, and we're like bagging, and we're doing all these things. And I remember her looking at me like, what do you think? I'm like, if we go now, we're good. And in our mind, we had this sort of mental clock, like, he's stable enough now. I think if we leave right now, and for us to leave, it still takes some time. We have to get a lot of stuff. Let's go. And so in our mind, and he went down, he's fine. He was in the hospital for a couple of days. We were still teetering on some old habits that were still there, that were hard to break, right? And I'm sure there are families that do the same thing too, that what happens when you wait too long. And we still walk that line.
Well, and you had a lot of history before S.T.A.R.S, right? It's ingrained in your brain, right? And what you dealt with before. So I want to fast forward back to Kellen had an ICU stay at one point when S.T.A.R.S was a fledgling program, right?
Yeah.
So talk to me about that. So you had a visit from someone who said, hey, y'all might want this thing that we're developing here. So tell me about that time.
That was amazing when complex care and then S.T.A.R.S were being born. And Trish, I remember her coming to see us in the ICU, and she was telling us about the program, and that what they want to do is educate, the people in our community that would be there, our support to help us outside of Cardinal Glennon that could help us handle emergency situations, and that they would provide the information on a regular basis to them, about his, what his equipment was, what his medical diagnosis was, what medical diagnosis, and then what the medicines were, and what emergency situations could possibly happen, and then work to actually train them. And we brought Kellen up, so then later on, organize the visit to actually go up and meet, all the possible individuals that could potentially be walking into our home. And so, showed them everything about Kellen. They got to meet Kellen. So that was really beautiful.
You're like,
experience.
wait, who are you? You lovely angel. And where were you like 10 years ago?
So they took the story we talked about, bringing the notes to the fire district. They sort of put a face to those people years later. We're like, introduce these. We're like, oh, you're the people that would have been. And here's his ventilator, and here's all these things. We're like, oh, nice to meet you. This is what we do. We're like, marriage, it finally happened. We got to finally meet him. And that was all because, that meeting when he was he was terribly sick. And we're like, she talked to us. We're like, oh yeah, that's another thing we're missing. We forgot. That's great. What a great program that would be to fill that huge, dangerous gap that sort of lives out there that people forget about.
So Kellen was one of the OGs. He was one of the original S.T.A.R.S kids.
Mm-hmm.
So, okay, Nick, we're going to get into the nuts and bolts here. So Kellen was one of the originals. Trish approached them saying, what do you think? Would this be good for you? Yes, please. It would be. So talk about this process for a family. How does one get enrolled in S.T.A.R.S? What are the steps? Kind of take us through from A to D or A to Z or whatever, however many steps there are.
Yeah, so the S.T.A.R.S program, whoever's working in the S.T.A.R.S program at the hospital will take the referrals. A lot of times we get referrals from like our complex medical care program, from our TCU and our NICU discharge coordinators. They'll look at a kid's STAR and they say, hey, we think this kiddo they meet your inclusion criteria, they should be in. And so we'll evaluate them and say, yeah, that kiddo should absolutely be in. And we'll write their plan on our website that we have. It's, through the S.T.A.R.S program, so that not only people here at Cardinal Glennon can access it, but also EMS can access it, outside hospitals can access it. Even if we operate on different medical systems, and electronic medical systems, we can still all share that across this common website. So we'll write the plans. The plans are generally written by staff at the S.T.A.R.S program. That's usually a nurse, a paramedic, a respiratory therapist. And it sometimes shocks people. They're like, doctors aren't writing this. And I can tell you what happens. No offense, I love our physician colleagues, but if you let them try to write a S.T.A.R.S plan, they will have you try to give experimental drugs from other countries. And we're like, I'm not sure what's on an ambulance. Let me, we'll write the plan based on what we think EMS can do in the area where this kid lives. We do still all get all of the plans are physician approved though. So after one of our team members finishes writing the plan, it gets sent to Dr. Stephen Laffey here at Cardinal Glennon. At St. Louis Children's, it's Dr. Joe Finney. So there's a pediatrician at each of the S.T.A.R.S hospitals who's in charge of saying, yes, this is appropriate care for this kid. This is what they need in an emergency. Even then, the plan is not quite live. It gets sent to the EMS agency so that their doctor can also review it and say, yeah, that's appropriate care for EMS to provide to the kid. And by combining those two steps, it allows us to really come up with a customized plan for that kid. This is exactly what this kid needs in an emergency. And we have people who have approved and said, yes, you can do this for this kiddo. And so that's at the heart of, or the nuts and bolts of how a S.T.A.R.S form is built.
That's a lot of work.
Yeah.
There's a lot that goes into that. I mean, like how many people do you have on the S.T.A.R.S team to help manage all of this work? I mean, there's got to be, there's training that's happening, the ongoing training, like you mentioned, like the hours that it takes to be a certified EMT, but then I'm assuming there's also some more immediate training, like whenever somebody gets on board. Can you kind of talk through what the employee logistics look like for this group of amazing individuals in the program?
Yeah, so there's two members who write and maintain the plans. So not only do we write them, but as Mr. Tim was alluding to, we want to keep them up to date. Like it doesn't do us any good to write a form that's now 5 years old and no longer accurate. So we actually receive a task every Monday morning of these plans have reached their 6 months. Somebody needs to lay eyes on them and update them and make sure they're up to date. So two people here at Cardinal Glennon are in charge of writing and maintaining the plans for Glennon, and then I have another employee who can kind of step in and backfill a little bit as needed. And so that person is also my data extraordinaire, which, as you all know, those people are amazing. And so, but she is able to kind of help us understand what we're doing in S.T.A.R.S and some things I think we'll talk about.
So who
shortly.
teaches the people? In other words, okay, we got Mr. Kellen enrolled. Okay, your S.T.A.R.S patient number, whatever. He's getting ready to go home. Who's in charge of taking his stuff? Here's his plan. Here's what this young man needs at home and what you could run into if they call, hey, need you, 911. Okay, who's in charge of teaching the paramedic people who are going to enter their door all about Kellen? Who does that?
So the same two people who write the plans, and then also we get some help from our outreach team for some of the situations, some of the kiddos. So it is a heavy lift. There's no denying it, but it's also, I think it's the stuff that makes the most difference, right? Like I could hop on a Zoom meeting and teach 200 people across the country, and just some random lecture I give about something in S.T.A.R.S, and they'd be like, okay, that was nice to know. But there's nothing like going to meet them, right? Like this isn't some hypothetical emergency that might happen someday. This kiddo lives down the street from your fire station. This is what you need to know about him. And so yeah, when we go out and provide that training, to me that's where people really learn, and it's where you really make a difference in the care.
Okay, so when a child's enrolled, they get a number, there's a care plan, there's all that. It all gets put in to this centralized database, right? And so it's this that's accessible by the hospital, by EMS, so anybody can get in there and see it. So correct me if I'm wrong, when Jamie and Tim call 911, when the call pops up, wherever it pops up for the ambulance or the paramedics or the operator or whoever answers the phone, which I'm stupid and I don't know, but it pops up that, oh, this is Kellen. He's a S.T.A.R.S patient, blah, blah, blah. Here's all his stuff, right? So it's all there. So in an ideal world, those people have been trained in at least minimally, this is what you can expect when you're going to go in. He's got a vent, he's got a trach, he's got a whatever. If the next step is, oh, and they've actually gone into his home and seen the vent, the specific one, seen where everything's at, that would be ideal, right? If all those parts happen before we need them. And sometimes all of that does happen, right?
Yeah, and I hate to use the word variability. I've used it a
Sure.
couple times today,
But no,
yeah.
that's the real world, right?
Yeah,
You
it's
have a
the
lot
real
of
world.
variables in your line of work.
That's
Yeah.
true.
Yeah.
So I think as many safety layers as you can add in will lead us most likely to the safest event, the best case scenario. And it unfortunately, just like EMS works differently everywhere across our region, S.T.A.R.S works a little bit differently across our region. And I think, yes, in the perfect area, we do ask our families, please lead with the S.T.A.R.S number, so you call and you say, I'm calling for S.T.A.R, 178. And then that tells the dispatcher something. And in some places, the dispatcher can actually already go ahead and activate something in S.T.A.R.S. In other places, they relay it to the crew. They say, hey, this is your S.T.A.R.S patient. And then the crew will go log in. And so, yeah, there's a number of different ways it works, but the goal is always, like ideally awareness beforehand. And I think that's something we had to overcome along the way. There was this belief that like, oh, well, we can just tag it somehow as either a paper form or a PDF, but like at the time of the emergency, people will get this. And listen, something's better than nothing, but you've called EMS, in fairness, when those people arrive in the middle of the night, I'm sorry, also wiping some sleep out of their eyes, and you hand them sheets of paper, that's like a really tough time to like trying to be scanned tons of paper. We want to know about this beforehand if at all possible. and also I think solving those things, like seeing your home beforehand. And so, some families have more bandwidth for that than others, but I certainly encourage it, if at all possible, to meet them beforehand. And I know you guys have done an amazing job with the guys in your area.
And you got to start somewhere, though, right? I mean, because like you said, it was sheets of paper in the beginning and binders in ambulances. Like, okay, here you go. Here's your tip sheet, but you started, right? It got started. So there was a recognition that we got to do better. We start with pen and paper and binders
Evolved
in
into a database.
in one thing, which evolved into a database, which evolved into a better version of a database, and so on and so forth. And I mean, it's been a process, and it's not over, because to your point, every district is different. Every district has different resources. It all operates differently, but we all know where we want to be, I guess. So how many patients are currently enrolled in S.T.A.R.S?
So as of this morning, there are 1,417 active S.T.A.R.S patients.
I'm sorry. You said as of this morning. Like, do you have like an average number that may join per day, or?
Yeah, so that's a good question. I normally think of it more in terms of month.
Okay.
So yeah, we're usually between 30 to 40 new patients per month.
So that's like almost one, if not more, per day on average.
Yeah, and that is spread across to 3 children's hospitals. But
So I assume the staffing goes up accordingly, right?
no,
Oh, and so the funding.
You're funny.
You just grow more
It does,
hands,
yeah.
right, Nick?
Oh,
You just got
I
okay.
forgot to put that on
It
my SWAT
doesn't.
plan, I think.
I'm sorry.
Yeah.
I'm sorry. Okay.
how many? So that's across 3 children's hospitals. What's that reach? Like, how many different EMS districts do you have, or counties, or however you equate that for your reach?
Yeah, so we work with about 159 EMS districts in the pre-hospital setting. That's kind of the eastern 2/3 of Missouri. And then we have a partner hospital in Southwest Florida that also covers a couple counties there.
Wow. So we're getting into Florida.
And all I can think is, why isn't it everywhere?
Yeah.
Are there only sick kids in these areas? Or
Yeah, we're
is
the
it
only ones.
Yes.
Yeah, so,
Well, let's just move to California or something, Jay. And all of a sudden, Kellen will be healthy.
yeah.
It
Yeah,
won't
no.
need EMS.
I certainly, I'm privileged to sit on a number of committees and meetings, and it's wanted everywhere, right? Like everybody wants to provide this, and I think we're just in the nascent stages of figuring out, okay, what does it take to build, a nationwide system, or even multiple systems that work together. But everybody, acknowledges that we want to help these kids, and we acknowledge all these problems that exist, and it's kind of just putting the right forces together to say, like, we can do better.
Yeah, my guess is we're not the only parents with these stories, that these scary stories. My guess is there's a whole bunch of them, if they were candid, that have needed it for so long and still need it, don't know it exists, or wonder why it isn't there. There's a lot of scared parents out there, I guess.
Well,
I
there's
could probably
over
speak for
1,000 easily.
that are
Just
in our
aware
area.
of it,
Right.
that are
Right.
aware it's there. So my guess is there's more that are out there going, wondering where this program is and need
It's
it.
exciting.
So is the database, this big animal of a database, is it able to pull reports and track outcomes, like, and say, yeah, like, we got a call and this was a S.T.A.R.S patient and this is what happened? Like, do we have, I mean, I know there's I guess, is there objective data to say we're doing well with this? You know what I'm saying?
Yeah, so we do use, it's actually a separate website that watches our website, and pulls data from it, and we do learn some things from that. We say, okay, who got into plans, who said they were getting into plans for emergencies, and as I alluded to my third team member earlier, a lot of her job is figuring out, okay, where did S.T.A.R.S calls happen, and going and getting trip sheets and data afterwards. So we can say, like, okay, what's working, where did it not work, how can we fix it, how can we get better outcomes? And so that's a lot of what her work is, and so she pulls together reports for me. So I mean, for instance, if you look at the end of 2023, so just the year of 2023, she was able to look at and say there were about 440 S.T.A.R.S emergencies that went out for last year. So we're averaging just over one a day, and So then we start to say, okay, who got transported by EMS, who got to stay at home, and start to really look into those. And it definitely informs our education. It informs our plan writing. To give you an example of how it informs our education, we look at, okay, why did 911 get activated for that S.T.A.R.S call? And it'll be of no surprise to the pediatric realm, but respiratory distress and seizures by far take the lion's share of the number of calls. But then we're able to also drill down and look at, okay, there were 5 tracheostomy calls. How did that go? Did they appropriately troubleshoot, or do we need to go do more education? So always trying to kind of inform what we're doing to be more impactful.
So this is one of a kind. S.T.A.R.S is,
It is.
right? It's unique. And I know it's been presented at multiple conferences, and it's been recognized for several awards, and it's received some national attention and things like that. It's really a unique model. So you talked about Florida. So it is expanding beyond Missouri and Illinois. What other hospitals have all adopted the program so far?
Yeah, so our partners across the street, St. Louis Children's Hospital is a partner in S.T.A.R.S, as well as Golisano Children's of Southwest Florida is our Florida partner. So if I could also give a shout out, they're not a formally S.T.A.R.S partner, but we work a lot with MU, formerly Women's and Children's in Columbia, who hosts some state resources for taking care of kids, and they do a lot of work with us. So.
Well, I just personally feel like the entire healthcare system has a responsibility to provide proper emergency care outside the walls of healthcare, right? Ultimately, we'd like to believe that paramedic education will evolve to a better place, right? To where we can do a little bit better and kind of catch up with the needs of our pediatric complex population. But until then, it's programs like this, programs like S.T.A.R.S that are absolutely going to improve outcomes of families and decrease provider anxiety, not just provider, paramedic provider, but caregiver, parent, provider, and apprehension and things while caring for these children. And I know Cardinal Glennon is incredibly proud of this program and that the foundation has provided some support, at least to help launch it, get a database going, do some FTE support or whatever.
And it's no coincidence that the logo is a sun, which is a star.
Yeah.
So we have the S.T.A.R.S program.
Oh, aren't you good?
I told you I'm a
Aren't
space
you
nerd.
good? Aren't you good? But the goal would be more outreach, right? And doing more, and that more hospitals adopt this kind of thing. But, the program provides no revenue to the hospital, and it's a free service. And I can't help but think that that is who we are at Glennon, which is one of the reasons we wanted to shout a little louder about this. Our whole mission is through our exceptional healthcare services, we reveal the healing presence of God. So we're doing that, and we're not getting anything for it other than what's right and how we should be.
And we're expanding it to other hospitals. It's not just about us. It's about the children and the patients out in the community, making sure that they have the best care possible, even when they're not in our walls.
So if there's an ambulance district, am I even saying that right? An ambulance district? If there's a district out there, if there's an ambulance worker out there who doesn't know about S.T.A.R.S yet, or they're like, man, this sounds like a great idea, we never even heard about this, how would they get on board with S.T.A.R.S? How does that happen?
Yeah. So, and if that was somebody here in the St. Louis area, that would just be them reaching out to us, and we do a contract with them. It's of no cost to EMS. It's no cost to Critical Access Hospital, but we are sharing healthcare information on a website. So we do have a contract in place for that. But after that, we would just designate, okay, who in your agency is responsible for this, and get them access so they could start taking care of their kids.
Like, how do they find you?
Well, the Glennon and the foundation websites often
Okay,
help them
there you
guide
go.
them to
Yes.
me, and so
Yes.
Put up the bat
Give
signal.
them your cell phone number. I don't
yeah.
know.
Or EMS is a
Yeah.
small community,
Yeah,
so
yeah.
people usually can find me some way. We do field a lot of questions from further abroad, and that's a little more challenging. So, and a lot of times I'll say, it requires your children's hospital to be part of it too. But we think it has to start there. We think it has to be driven by the hospital also wanting to expand the care from beyond its four walls out into the field. And it takes both. Don't get me wrong. It takes EMS, it takes children's hospitals. It takes a bunch of people who care. I mean, I love S.T.A.R.S and, like you said, the website and the registry and all this stuff. But at the end of the day, those are just tools for people who care about improving this. And so a lot of times I'll just share with other groups, like, these are the lessons we learned. And I try to share those into the world because I want to save everybody about 8 years of knocking their head on brick walls. So, but this is what we learned as we went through this journey and this process, so that we can have improvements, nationwide. I truly am a believer of, a rising tide raises all ships, right? Like, we just have to bring awareness and then fix emergency care from EMS, from critical access hospitals, and from our own hospitals. How do we keep improving at what we're doing here? And so that's,
I can tell you it, as a parent who has heard a lot of information on where to get resources, that I've had so much going on mentally that I forget everything that's been told me. We've talked about this over the years with, like, as when you're dealing with complex children, there's so many resources that are out there, but you don't know where to find them all. It's very difficult, right, to get them to you, right? And so I remember so many years talking about this, going, I always felt like if somebody came and talked to me about 6 different things, I would take away 1. But all the other 5 may have been so important, but I just didn't have the mental capacity, because I'm thinking, like, okay, how's he doing? Is he okay? It's just such a burden to care for a complex child. And one of the things that I would tell you, as if you're talking to a family like ours, is don't give up the message. We probably didn't hear you the first 5 times, but we need you. And so in the hospital, when I'm thinking about this, like how we found out, is we get Footprints visit us. We see you. We see everybody comes by and visit. It's awesome. And they talk to us, and we learn about programs that didn't exist. But my guess is, again, if you can bring this up during, even if it's maybe not a well visit, but some kind of visit, to let them know that this program exists. And if no response comes out the first one, they probably just threw it. They probably forgot about it because they were just wanting to get through that day. But if you continue to force it on them, there's a million stories like this. Like, we found programs that were like, they're like, well, we've talked to you about this for 4 years. Like, no, you didn't. Oh, you did. Whether it's therapy, whether it's like, we're like, we didn't know that was available. It's like, it's always been, but we don't know. We don't have the mental bandwidth sometimes to go, like, let's go hunt it down. If we have to hunt it, we're like, we ain't have time for that. But if you can sort of force it on us in those situations, we'll bear with us. We'll get it. We'll listen, and we know it's there. It's that important. I think that's, for me, a good way to let us know.
What other thoughts do you have about this, as parents? Because, I mean, you're the customer. You're the ultimate customer.
Well, and the end-all caregiver too. I mean, this is...
Well, I mean, my only question is, what can I do? Because what I recognize is Kellen is the most important thing to me, but I know how important this is for all the families. So what can I do to assist you? And, whether it's sharing our story or being a resource or coming to trainings, I'm like, what can I do?
yeah, I mean, it's all those things. It's your support, helping us with trainings is actually a massive thing. And it's one of those where I ask families, but I don't like to push. And I might not push multiple times on that one, Mr. Tim. But
Whatever.
But I do think, like, once again, it's that anchoring, right? Like, this is real.
Yes.
So, like, this isn't something on page 473 of the textbook. Like, this kid exists in the world. He needs you to know how to care for him. And so, for instance, even just, at the start of the pandemic, when everything was shut down, your family helped us record a video for how to take care of a kid at home via Teams and Zoom when those were brand new words in everybody's lexicon. And so, I think that a willingness to support us there. helping us create education that can be rolled out for other kids, especially, for other kids where they might not be in a position to be able to help train for their district. And then I think also just, I want to help take some of the burden back off the families. I think the national model for a long time has been like, yes, you, mom and dad, like we told you about 22 programs. Here's 400 sheets of paper upon discharge. And by the way, you need to go drive by your local fire or ambulance district and tell them that you live there. And, well, I hope that you can do that. And I think it's important to stay in contact with them.
Mm-hmm.
If you're able to do that, cool. If you're able to still come up as part of the presentation, but also know that part of what I'm trying to do is help you remove some of that burden so you don't have to do all that communication.
Yeah. So, and I would never want to miss this opportunity to talk about, like, not just the stars, but the caregivers. Cause I think sometimes I think we're just hearing ourselves talk like we do it all, right? Like we're like some kind of superhuman. Nobody has our secret, right? And it's just,
you do.
No, it just couldn't be farther from the truth. Like there are so many people at Glennon for sure, but even nurses in our home, and just down to therapists or people that visit with its footprints, or whether people like you that would take care of the caregivers and the nurses, or that do just sometimes the smallest fraction of thing. And then they go home and I think, whatever, I just did a shift and it was like everything was fine that day. And we're over here going, thank goodness we can sleep for like 5 minutes, or we can take a nap. And it all plays into like this. And I always tell them all the time that like you all play such a bigger role that you probably don't ever think you do, because you don't ever realize from our side what we benefit from it. But it's so impactful. And this is just one part of the program, like coming in and saving the day. It sort of happens. And we have all these things that happen so many times during a day, and then it's just a small, the therapists come in and they'll work with them for like 30 minutes. We're like, we thank goodness you're doing it, because I just don't think we could give it. We could stretch them. We could do all, we could, we just we can't. So they come in for like 30 minutes, they work them out a little bit and then they leave or something, or they come and do something for a little bit. And you think, what kind of impact did I possibly make? And like, oh yeah, you took like one thing of 1,000 things off our plate. Thank goodness. Now we can actually, go grab a bite to eat or something like that. So the Glennon staff, whether it's the different, whether it's neurology or respiratory, or whether it's the EMS group, or whether it's the people that support the people, or, the school district locally, they all play this major role in helping us do this. And I just can't imagine getting this opportunity and not thanking them for what they do, and that little part of the role they play in our life and making it better. I hope they understand how important they are. That is just, they don't take it, take it for granted. We don't. We understand.
We don't take it for granted.
If I could even share just specific to EMS out of those people, you have like, that's a pretty amazing group of people, right? Like there are a group of people who like are willing to wake up at 3:30 a.m. across this entire country, and at the drop of some music from the ceiling, they're going to drive out to your house and come try to help you with something. And so yeah, I think that I'm still amazed, like at the field. I accidentally got there, like many paramedics. I didn't like aim straight there, but I found my way there, and it's an amazing group of people. And it's just, it's a tough job, like to know it all. And I think, this program was never meant to say like, oh, you guys didn't know that, that's why we had to create this. No, like it's too much to know. We need safety systems. We need ways to improve it all. And so, yeah, I just, like I said, those people are awesome, and these families are awesome, and the children's hospitals are awesome. And how do we just tie that all together to keep improving?
Well, I'd like to say I went from a lens of not really reality with my Rescue 911 lens, thinking that everything was perfect, right? And that we didn't need such a thing as S.T.A.R.S. From my lens of ignorance to, no, we have a S.T.A.R.S. Like, oh, and that's cool. Like, duh. Like, it's a duh, really. Like, this is
why would you not do this?
Like,
yeah,
right. Like, so I went from thinking it was just there already to, oh, it's not, but we have S.T.A.R.S., So I went from one like cloudy, not smart, ignorant lens to oh, and it's here. And I don't want, I'll get emotional. I don't want to picture Glennon having not embraced this, right? For a family like you. I don't want to think about you being alone. Like, I don't want to think about that and or feeling alone. And I don't want to think about these 1,000 other families that have to do what you do every day. I don't want to have to think about the families that don't have stars in their area. Like, I almost can't think about it now, because I do know that there's a gap, and I do know that it's a problem and that it's not nationwide. And I don't like to think about that. That's painful. So I'm very grateful to work for a Cardinal Glennon that does things that aren't money makers, but that are just the right thing to do. And it makes me proud. And I wish you and your team everything that you need and all the resources that I don't have personally to do what you do, because it's God's work. It truly is. And I just want to be part of, and I think that's why we're here today, part
Absolutely.
of being louder and being proud of who you are. And I just want to thank you, and thank you guys for helping us be loud and talking about what's an amazing thing. Y'all are stars.
We hope you enjoyed this episode of The Glennon Factor. Make sure you follow The Glennon Factor and leave us a review wherever you get your podcasts. Visit Glennon.org if you would like to learn more about how you can support Cardinal Glennon kids. And while you're there, feel free to share any feedback or episode suggestions on our podcast page. The Glennon Factor is recorded and produced by SSM Health Cardinal Glennon Children's Foundation. You got to pat.
So cute.
You got to pat your legs to get the rocket ship going, Laura.
Yeah. Going on a trip in my favorite rocket ship. It's great. Look it up. It's fun.
I really hope this is the first time. Hopefully, you guys will be in the tag now. So.
Ages 1 to 55. You can listen to that. It's great.